Hey nursing students, Miss Midoff here. Today we're going to talk about ears, eyes, and upper airway. Let's get started. Our objectives are, we're going to talk about acute airway obstructions such as OSA or obstructive sleep apnea, Epistaxis, nasal obstruction, fractures of the nose, laryngeal cancer, macular degeneration, orbital and ocular trauma, pathology of the external, middle, and inner ear, retinal disorders. Some diagnostic procedures are audiometry, a laryngoscopy, and middle ear endoscopy. Airway obstructions. Let's talk about obstructive sleep apnea. Obstructive sleep apnea is cessation of breathing or apnea during sleep, usually caused by repetitive upper airway obstruction. It also causes a reduction in ventilation, and it's mostly prevalent in those individuals that are of older age. It affects the men more than women, but we do think that 90% of individuals are not diagnosed. We've also seen an increased rate of obstructive sleep apnea because of increased rates in obesity. Any structural changes such as tonsillar hypertrophy, abnormal posterior positioning of one or both jaws, and variations in craniofacial structures also increases risk for OSA. We have primary, secondary, tertiary prevention. Biggest thing is we want to educate our patients. We want to make sure that we help manage their weight because this is a risk factor. We want to have early diagnosis. We do know that 90% of them go undiagnosed. And we're going to talk about the clinical manifestations of it. So if you have a patient that is telling you these signs and symptoms, early diagnosis, screening, and treatment and follow-up are paramount. The pathophysiology is a decreased tone in the muscles when we sleep. This in turn reduces the diameter of the upper airway. It's coupled with small amounts of negative pressure generated during inspiration while sleeping. This may result in upper airway collapse. We do know that the long-term complications of repetitive apneic episodes result in hypoxemia and increased hypercapnia, which triggers a sympathetic response. In long term, if this is happening every night, patients with OSA have a high prevalence of hypertension, which goes hand in hand with the high rates of obesity, risk of MI go up, and stroke. And all of these could be mitigated with early treatment and prevention. The clinical manifestations, I do urge you to refer to chart 22-4, which is on page 568. What I need you to look at is the 3 cardinal signs of obstructive sleep apnea. So snoring, they complain of sleepiness, and they have sleep apnea episodes, which is breathing. They stopped breathing for 10 seconds or longer. Medical management. For medical management, we want to diagnose early. So clinical features coupled with a sleep study called a polysomnographic finding. And what that is the patient is hooked up to several monitors and their sleep is analyzed overnight. What we're going to have them put on is an EAG, which analyzes their stages of sleep, an electrooculogram or chin electromyogram, which looks at the position of their upper airway. They're being monitored with an EEG, an EKG for any dysrhythmias. The airflow of their nose and mouth is monitored using a thermal sensor and nasal pressure transducer. Breathing effort is monitored as well as hemoglobin saturation. The mechanical management, we can manage OSA using a mandibular advancement devices, which helps prevent the collapse of the upper airway. We also prescribe CPAP and BiPAP to help that upper airway from collapsing. Behavioral management, we want to control their weight because we know that this is a risk factor. We want them to avoid alcohol because it does depress the nervous system that could help further collapse the upper airway. If there's structures in the upper airway that are obstructing the airflow, they might need a surgical management such as a tonsillectomy, uvulopalatopharyngeoplasty, try to say that 5 times, or any of the other surgeries listed there, like maxomandibular surgery or septoplasty, and we'll talk a little bit more about that a little bit later on when we talk about nasal fractures. But for pharmacology management, if they're already prescribed a CPAP, a BiPAP, or a MAD device, then what we can do if they're still having daytime sleepiness, to reduce that, we can administer them Provigil or Triptyl, which given at bedtime can increase the respiratory drive and improve upper airway muscle tone. Provera or Diamox have been used for sleep apnea associated with chronic alveolar hypoventilation. The patient, though, with pharmacological management needs to understand that these medications are not a substitute for CPAP, BiPAP, or MAD. We do want them to be compliant with the CPAP or the BiPAP. Our nursing interventions, we want to explain what OSA is, what symptoms are cardinal to it, the treatments, so we would be helping explain how to use the BiPAP machine, risk of untreated OSA, the complications, and we've already talked about it, and the benefits or the evidence of success that it's working. The American Sleep Apnea Association is there for you. The link is there if you have any more questions or want to refer your patients to that website. Next, we're going to be talking about Epistaxis. So the definition of this is a hemorrhage from the nose, so bleeding, that is caused by the rupture of tiny dissected vessels in the mucous membrane of any area of the nose. Now, typically, the most common sites are in the anterior septum, where the 3 major blood vessels enter the nasal cavity. So we're looking at the ethmoid arteries, the sphenopalpatine artery right there, or the internal maxillary branches. They're not pictured here, but we're talking about any one of these arteries. Several risk factors are associated with Epistaxis, and I'm going to refer you to chart 22-5. The risk factors are if a patient has local infections or systemic infections such as a scarlet fever or malaria, if they have frequent drying of the nasal mucosa membranes, if they inhale nasal corticosteroids or use illicit drugs, blunt trauma, or even picking your nose too forcefully can cause bleeding because it breaks the brittle blood vessels in your nose, or arteriosclerosis, hypertension tumor, a tumor in your nose, or thrombocytopenia, use of aspirin, or liver disease can all cause Epistaxis. For medical management, it depends on its cause and the location of the bleeding site, but we want to determine where the cause is, and we need to stop the bleed. But if it's any of the underlying medical conditions, such as use of aspirin or hypertension, we want to treat the cause, of course. Nursing management, we want to assess vital signs. We want to assist in controlling the bleed. We want to make sure that we apply firm, direct pressure. We don't want the patient to lie down because of aspiration, but we want to have the patient sit upright with the head tilted forward. And we want to direct the pinching to the soft outer portion of the nose against the midline septum for about 5 to 10 minutes continuously. We can apply a nasal decongestion, 1 or 2 sprays, and this acts as a vasoconstrictor. If these measures are unsuccessful in stopping the bleed, then we can then cauterize it. This is a little bit more of an intense management, but if we need to suction, we can also use that. We want to educate our patient to avoid vigorous exercises for 7 days and avoid hot or spicy food, because all of these can cause vasodilation and increase the risk of bleeding. Humidity plays a factor. If it's really dry heat, it can dry the nasal passages and make those vessels really brittle and bleed. We want to prevent or minimize those risk factors that we talked about in chart 22-5. Nasal obstruction. Causes of nasal obstruction range from deviation of the nasal septum, hypertrophy of the turbinate bones, or pressure of the nasal polyps present in the nasal passages. Chronic nasal congestion forces the patient to breathe through the mouth, and this can cause dryness of the oral mucosa and associated problems, including persistent dry oral mouth or cracked lips, and that's one of the complications listed there. If the patient has chronic nasal congestion, they often suffer from sleep deprivation due to trying to maintain adequate airway. And chronic infections like nasopharyngitis or rhinosinusitis or pain can often ensue. Medical management revolves around removal of any obstruction, include non-surgical and surgical techniques. We want to treat the underlying infection if it exists, treat allergies and infections or surgical procedures if needed. For nursing management, when a medical procedure is coming, then most often we need to, we're going to be involved with the patients in an outpatient basis. We explain the procedure to the patient. Post-operatively, we elevate the head of the bed to promote drainage and to alleviate discomfort from any edema. We want to provide frequent oral hygiene to prevent from the mouth from drying out. Before discharge, we want to instruct the patient to avoid blowing the nose with force, especially during the post-operative recovery period, because then that can lead to an epistaxis episode and subsequent swelling. The patient is also instructed about the signs and symptoms of bleeding and infection and when to contact the healthcare provider. Fractures of the nose. Fractures of the nose is the most common facial feature and most common fracture in the body, and it's usually caused by an assault. The complication comes from a fracture of the nose. We have a nosebleed, we have hematoma formation. It can lead to infection or abscess or avascular or septic necrosis. The clinical manifestations is, of course, pain, bleeding, swelling, and periorbital ecchymosis. And we'll talk a little bit more about ocular and orbital trauma a little bit later on. But nasal obstruction, there it is, deformity, asymmetrical appearances. The assessment and diagnostic findings, usually the nose is examined internally to rule out the possibility that the injury may be complicated by a fracture of the nasal septum and a submucosal septal hematoma. Intranasal examination is performed in all cases to rule out septal hematoma, which it's that picture listed right in the middle. Because of the swelling and bleeding that occur with a nasal fracture, an accurate diagnosis can be made only after the swelling subsides. We want to pay close attention to clear fluid draining from either nostril, suggesting a fracture of the cribriform plate or the basilar skull fracture with leakage of the cerebral spinal fluid. The X-ray that we do as a diagnostic finding usually reveals displacement of the fractured bone and may help rule out extension of the fracture into the skull. Medical management is first off ABC, ensure patient airway and rule out cervical fracture. Bleeding usually of the nose is controlled with the use of packing. We use cold compresses as a use to prevent or reduce swelling at first. And for the patient who has sustained enough trauma to break the nose or any facial bone, we want to rule out any cervical spine fracture. Uncomplicated nasal fractures can be initially treated with antibiotics, analgesic agents, and a decongestant nasal to vasoconstrict those vessels. Treatment of the nasal fracture is aimed at the facial appearance of the nose, goes back to the way it looked as much as possible. And the patient is usually referred to a specialist to evaluate the need to realign the bones. Although improved outcomes are obtained when reduction in the fracture is performed during the first 3 hours after the injury, this is often not possible because of the edema. So we need to let the swelling go down, ideally within 3 hours or 3 to 7 days of severe edema present. And if there is a hematoma, Then a septorhinoplasty is performed when the nasal septum needs to be repaired. For us as nurses, we want to immediately apply ice after the fracture and encourage the patient to keep the head elevated. We want to instruct the patient to pack the nose if there is bleeding, and after the bleeding has stopped, then we want to monitor for mucosa or dryness, the mucosa for dryness, lacerations. We want to medicate, use analgesic agents such as acetaminophen or NSAIDs to help with pain management. We want to tell the patient to avoid sports following for 6 weeks to prevent it from re-injuring the nose. Laryngeal obstruction. This is an obstruction of the larynx because of edema. It's a serious condition that can be fatal without swift, decisive intervention. The biggest thing here is that the patient larynx can become stiff and they can suffocate. The causes are caused by acute laryngitis, urticaria, or severe inflammation of the throat, usually caused by like scarlet fever or severe anaphylaxis, or if a patient has a familial hereditary angioedema that runs in their family, or of course, just the cardinal sign of choking because of food or something gets stuck in the patient's throat. A child sticks something in and they can't pass it because their airway is really small, but this is a medical emergency. Obviously, clinical manifestations would be lowered oxygen saturation. They're going to try to use their accessory muscles in order to get air into their lungs, and the neck and abdomen retractions are going to be able to be seen. Assessment and diagnosis, definitely treat the patient. We want to, again, find a patent airway and remove anything if there's a foreign body. If there's infection, we want to treat the infection. Definitely want to see what their history is, if they've had poor dental procedures, or if there might have been an infection that's causing the laryngeal obstruction. Previous surgeries or radiation also can swell the passages and cause laryngeal obstruction, or even trauma. We want to ensure a patent airway, treat the cause. If we can't open up the patient's airway, then if in the hospital setting, we're going to do a tracheostomy and treat with appropriate medications such as epinephrine for an allergic reaction, or corticosteroid to decrease that inflammation, and definitely want to monitor the pulse ox of the patient. Ice can be also applied to the neck in an effort to reduce edema. Laryngeal cancer. Laryngeal cancer accounts for approximately half of all head and neck cancers. About 13,560 new cases occur, as well as 3,640 deaths annually. There is a 5-year relative survival rate, and almost all malignant tumors arise from the surface of the epithelium, or the squamous cell carcinoma. Approximately 55% present with involved lymph nodes at the time of diagnosis with bilateral lesions are present in 16% of clients. It can reoccur, usually within 2 to 3 years after diagnosis and it being treated. Presence of disease after 5 years is often secondary to a new primary malignancy. Incidence of distant metastasis from squamous cell carcinoma of the head and neck is relatively low. For risk factors, look at chart 22-6, but they include tobacco use, alcohol and tobacco, exposure to asbestos, secondhand smoke, paint fumes, wood dust, cement dust, chemicals, tar products, nutritional deficiencies, or genetic predisposition. Gender, it's more common in males and occurs usually after age 65. More prevalent in African Americans and Caucasians, and those, of course, with weakened immune systems. Clinical manifestations. Hoarseness is usually the first thing that we see with someone that has laryngeal cancer. Hoarseness that persists greater than 2 weeks usually occurs in those patients with cancer in the glottic area because the tumor impedes the action of the vocal cords during speech, but this is not always present. The patient's voice may be harsh and sound raspy and lower in pitch. Affected voice sounds are not always early signs of subglottic or supraglottic cancers, however. The patient may complain of a persistent cough or sore throat and pain and burning in the throat, especially when drinking hot liquids or citrus juices. A lump may be felt in the neck, and later symptoms include difficulty swallowing, such as dysphagia, dyspnea, difficulty breathing, unilateral nasal obstruction or discharge. Again, there it is, persistent hoarseness and ulceration and foul breath. Cervical lymphadenopathy or unintentional weight loss, generalized debilitated state, pain radiates to the ear where it has metastasized. On our assessment, we're going to want to do a thorough history and physical examination of the problem area. In this case, it would be the head and the neck. We would want to do an indirect laryngoscopy or an endoscope. We'll talk a little bit more about this diagnostic exam a little bit later on. The lymph nodes of the neck and the thyroid gland are palpated for enlargement. Diagnostic procedures include a fine needle aspiration biopsy, and this is done on initial screening to obtain samples of any enlarged lymph nodes in the neck. A barium swallow study is done if the patient usually complains of difficulty swallowing. In some cases, a direct microscopic visualization and palpation of the vocal cords may yield a more accurate diagnosis. We also want to do a CT scan and MRI to assess regional adenopathy and soft tissue, and to stage and determine the extent of the tumor if we think it's metastasized or grown larger in size. An MRI is also helpful in post-treatment follow-up to detect a reoccurrence, and PET scanning may also be used to detect reoccurrence of the laryngeal tumor after treatment. The goal of treatment of laryngeal cancer include cure, preservation of safe, effective swallowing, preservation of useful voice, and the avoidance of permanent tracheostomy. The treatment options include surgery, radiation therapy, and adjuvant chemoradiation therapy. The prognosis depends on the tumor location. So is it supraglottic, glottic, or subglottic, as well as the tumor grade and stage, usually using the TNM system. The treatment plan also depends on whether the cancer is an initial diagnosis or reoccurrence. In addition, before treatment begins, a complete dental examination is performed to rule out any oral disease. Any dental problems are resolved, if possible, before surgery and radiotherapy, because we don't want that risk for infection. For patients with early stage tumors like stage 1 and 2 and lesions without lymph node involvement, we use external beam radiation therapy or conservation surgery, which is less invasive surgery such as vocal cord stripping or cordectomy. And these are usually effective for those early stage tumors. Other indicated surgical procedures, we can do a transoral endoscopic laser excision or partial laryngectomy. And we'll talk a little bit more about these medical managements a little bit later on. Patients with stage 3 or 4 tumors that are resectable may be advised to have either a total laryngectomy with or without post-operative radiation therapy, or radiation therapy with concurrent chemotherapy, an agent like cisplatin, and a surgical resection aimed at preserving some of the larynx. And this is an organ preservation surgery. Patients with late-stage tumors that extend through the cartilage and into the soft tissue are generally advised to have a total laryngectomy with post-operative radiation therapy. Patients should be educated so they can carefully consider what their options are and the different treatment modalities. Supraglottic tumors metastasize early and bilaterally, even when there appears to be no lymph involvement at the time of diagnosis. So we've got to be very careful with these. When the neck lymph nodes are involved, the treatment includes surgery, chemoradiation, or both, because we don't want it to metastasize further. Surgical management. We talked a little bit about vocal cord stripping. And vocal cord stripping is used to treat dysplasia, hyperkeratosis, or leukoplakia. And it's curative for these types of lesions. So what this is a procedure that involves removing the mucosa of the edge of the vocal cord using an operating microscope. Vocal cord lesions are initially treated with radiation therapy. So you're taking away anything that could be significant for laryngeal cancer. A chordectomy is an excision of the vocal cord and is usually performed via transoral laser. This procedure is used for lesions limited to the middle third of the vocal cord, and the resulting voice quality is related to the extent of the tissue removed. So in next slides, in like 2 or 3 slides, I'm going to have YouTube links of these types of procedures, and they talk a little bit more about, how it works and what they use it for. Laser surgery. Laser surgery is well known to have several advantages for the treatment of early glottic cancers. Treatment and recovery are shorter with fewer side effects. It can be less costly than other forms of therapy, and it can be used for treatment of many laryngeal tumors, with the exception of large vascular tumors, because those have a tendency to bleed. When compared with the results of other treatments for early laryngeal cancer, laser microsurgery is considered to be a method of choice based on patient outcomes. Partial laryngectomy. A partial laryngectomy is often used for patients in the early stages of cancer in the glottic area when only one vocal cord is involved. So this surgery has a very high cure rate. It can be performed for reoccurrence when high dose radiation has failed. What this is a portion of the larynx is removed along with one vocal cord and the tumor, but all other structures stay intact and they remain. The airway remains intact, and the patient is expected not to have any difficulty swallowing. The voice may change some, or the patient may sound hoarse. With total laryngectomy, we're looking at the complete removal of the larynx, and this can provide a cure in most advanced laryngeal cancers when the tumor extends beyond the vocal cords, or for cancers that recur or persist after radiation therapy. In total laryngectomy, the laryngeal structures are removed. So this includes the hyoid bone, the epiglottis, the cricoid cartilage, and 2 of the 3 rings of the trachea. The tongue, the pharyngeal wall, and most of the trachea are preserved. So I did have a link to a YouTube video for a total laryngectomy, because this is something that you, as a healthcare provider, need to know, that when a patient has a total laryngectomy, no longer are they breathing through their nose or their mouth, but the stoma. So if this patient were ever to go to through cardiac arrest, and you were to bag this patient, because if you were to think about the oral as the top third of your breathing tube, then the middle third would be your the second third would be the larynx, so the middle portion, and then the third part being your trachea, and then it bifurcates or it splits into your bronchus. If you're looking at a total laryngectomy, they've basically taken out and disconnected the top part, your oral and nasal pharynx, from your trachea. And what stands in place is your stoma. So in an emergency situation, you're not going to want to bag the patient through the mouth, because there is no connection between the mouth and the bottom half of the trachea with a total laryngectomy. So you're going to want to bag via the stoma that is placed in their neck. Occasionally, these patients continue to have a laryngectomy tube in the stoma, and they're going to need a prosthetic device such as a Bloom-Singer valve to speak without aspirating. And I have YouTube video links on how a patient's voice changes, and we'll talk a little bit more about the speech therapy a little bit later on in this slide. But the tracheostoma prevents the aspiration of food and fluid into the lower respiratory tract. The patient at this point has no voice, but does continue to have normal swallowing, because we're talking about 2 different types of tubes. The 2 tubes, the first one is the trachea, that is where we breathe. but then the swallowing happens through our esophagus, which is behind the trachea. So the swallowing still continues as needed, but we do want to make sure that they don't aspirate. Like I was mentioning, the total laryngectomy changes the manner in which airflow is used for breathing and speaking. And so you want to look at figure 22-4 for that. Complications that may occur include a salivary leak, wound infection from the development of a pharyngocutaneous fistula, stomal stenosis or closing of the stoma, and dysphagia secondary to esophageal strictures. The goal is to eradicate the cancer and preserve the function of the larynx, but if that can't be possible, then we want to make sure that we minimize the complications of the laryngectomy. In some cases, the patient may be a candidate for a near total laryngectomy, which is what I haven't talked about. And in this situation, the patient would be a candidate for chemoradiation therapy regimens post-operative. What we want is voice preservation that can be achieved in most cases and tends to be associated with overall improved quality of life. Radiation therapy. We want to eradicate the cancer and preserve the function of the larynx. The decision to use radiation therapy is based on several factors, including how big the tumor is, and the patient's overall health and lifestyle, occupation, and personal preference. There has been really good results that have been done with radiation therapy in patients with early stage glottic tumors when only one vocal cord is involved and there is normal mobility of the cord, as well as in small supraglottic lesions. One of the benefits I want you to note of radiation therapy is that patients regain a near normal voice, which is a huge plus. A few may develop chondritis or inflammation of the cartilage or stenosis, and a small number may later require a laryngectomy. Radiation therapy can also be used preoperatively to reduce the tumor size, and it can be combined with surgery in advanced laryngeal cancer as another therapy to surgery or chemotherapy, and also as a palliative measure to help them with breathing and pain and all of that. Complications from radiation therapy and the results out of external radiation to the head and the neck. And some of those could cause like acute mucositis, ulceration of the mucous membranes, pain, dry mouth. Most of the time with radiation therapy, the patient complains of difficulty swallowing, fatigue, their skin, they have skin reactions, they lose the taste, their ability to taste food, which in a total laryngectomy, because you're bypassing the nasal pharynx, cranial nerve 1, the patient is going to have a little bit of a difficulty tasting food after they have a total laryngectomy. Speech therapy. Speech therapy is a very high component, interdisciplinary health measure that we're going to need to work closely with patients that have laryngeal cancer. With a patient that has a total laryngectomy, they potentially face complex challenges, especially those when it comes to communication. So the speech therapist is going to want to talk to the patient and the family members before surgery to discuss what's going to happen after surgery. The nurse, as nurses, we're going to have to discuss with the patient and family the methods of communication that will be available in the immediate post-operative period, because they're not going to be able to talk after getting a total laryngectomy. These include writing or lip speaking and reading, communication with a word board or an Etch-a-Sketch or something like that. A system of communication has to be established with the patient, the family, the nurse, and it's very troublesome and frustrating for the patient, because when you're used to communicating and now you can't, it's very frustrating. So we want to pay attention to their mental, emotional, and psycho health for patients that have gone through these types of surgical procedures. And we're going to talk a little bit more about the 3 most common types of techniques of alaryngeal communication. Esophageal speech is when the patient needs the ability, has the ability to compress air into the esophagus and expel it. And I have a YouTube link in the following slides. They can also have an artificial larynx, and some words may be difficult to understand with this type of speech, and it's is not always successful until the patient masters this technique. An electric larynx may be used for communication. It's a battery-operated apparatus that projects sound into the oral cavity. A transesophageal puncture, this is associated with high phonation success. It usually has good phonation quality, steady long-term results, so this is widely used. A valve is placed in the tracheal stoma to divert air into the esophagus and outside the mouth. And look at those YouTube videos, they're going to help a lot. Kind of already talked about how you would want to get a full health history. We want to focus our physical assessment on the head and the neck with an emphasis on the patient's airway. We want to palpate for swelling or nodules or adenopathy. We want to get speech therapy involved. We want to assess how well the patient reads and writes, because this is going to be the way that they communicate later on, and it might restrict some of the methods that we can communicate with them. Visual impairment and functional illiteracy can make it difficult for the patient to communicate afterwards, so we need to assess for this. We want to assess the patient for alcohol abuse and risk for alcohol withdrawal syndrome after, if they're stopping cold turkey because of a procedure like this. We want to talk to the patient about being ready to stop smoking. We want to do a psychological readiness assessment for the patient and the family. And we want to talk about their fears and their coping mechanisms and support systems that they have in place. Our nursing diagnosis would be maybe deficient knowledge about the surgical procedures and most post-operative course. So our planning and our goal would be to increase their knowledge. Anxiety related to the diagnosis of cancer or their surgery, we want to decrease their anxiety. That's our goal. We want to make sure that they maintain a patent airway. So a diagnosis that's relevant to this type of patient is an effective airway clearance related to excess mucus production. Impaired verbal communication is definitely something that's huge. So we want to have effective alternative communication in place. Imbalanced nutrition. And so we want to make sure that they're hydrated and properly receiving nutrients to heal properly. Their body image is going to be altered. So we want to make sure that we talk to them about the way it's going to look and how it's going to be different later on. Isolation and self-care deficit is also another appropriate diagnosis. And again, we want to involve the respiratory therapist for any respiratory distress, involve the team with any hemorrhage or infection or wound skin breakdown or breakdown of the stoma, and aspiration, and collaborate with other healthcare team members to make sure that these patients are taken care of. So we talked about laryngoscopy a little bit, and the purpose of this is to visually inspect and examine the larynx using a fiber optic tool. Before the procedure, we want to maintain the patient in NPO status. We want to look at their coagulation to make sure that they're not going to bleed. We want to remove any dentures, eyeglasses, start an IV. We want to make sure that we have the emergency equipment needed in case we need to maintain that airway and breathe for them. Post-procedure, we want to maintain the patient in a semi-Fowler's position to maximize airflow and oxygenation. We want to assess for gag reflex, and we want to make sure that we don't give them anything until this returns. We want to monitor for bloody sputum and respiratory status. And complications of the laryngoscopy are spasms or facial neck crepitus, dysrhythmias, hemorrhage, hypoxemia, or a pneumothorax if they go too low and puncture the lung. Now we're going to move on to macular degeneration. I do encourage you guys to take a break if you guys haven't done so already, but let's move on after. You can pause this and then come back and we'll talk about macular degeneration. But macular degeneration, etiology, and risk factors. Age-related macular degeneration accounts for about 50% of all blindness in older adults. So it's categorized by these tiny yellow spots called drusen that happen underneath the retina. And these clusters of debris or waste material happen all along the retina, but it's when it's located in the macular area that it affects vision. Most people older than 60 years have at least a few drusen spots, which are clusters of debris, like I said, or waste material. Patients with AMD have a wide range of visual loss, but only a small portion experience total blindness. Central vision is generally the most affected, with most patients retaining peripheral vision. Look at figure 63-13 in your book. And then we're going to talk a little bit about the two different types of AMD, the dry type and the wet type. The dry or non-neovascular exudative, what this is that outer layers of the retina slowly break down and drusen appear. It's caused by gradual blocking of the retinal capillaries, so it's obstructive. And this leads to ischemia and necrotic macula, which means that the rods and the cone photoreceptors in that area die, and so we're no longer able to see the vision. In exudative, neovascular, or exudative wet, we have a serious detachment. So there's fluid that is released, and this fluid and blood collect under the macula, and there's a pool of this fluid and blood that results in scar formation and visual distortion. It's usually more of an abrupt onset, and what the patient's going to see is straight lines that appear crooked or distorted, or letters that are broken. You want to also look at figure 63-12 and figure 63-13. There is no known effective therapy for age-related macular degeneration. So an important component of treatment for wet, though, is that we want to target the development and the progression of angioneogenesis, or the abnormal blood vessel formation. What we know is that in wet macular degeneration, the production of abnormal blood vessels is usually caused by an underlying angiogenic stimulus known as vascular endothelial growth factor, or VEGF. Examples of these inhibitors that we give the patient: Lucentis or Avastin. And what they do is they help these blood vessels from growing, and they help stop or prevent the bleeding from leaking from these blood vessels. So we want to initiate strategies to assist in maximizing the vision that they do have, maintain the patient's independence, and we want to provide referrals to community organizations that could help them, support groups. If indicated, we want to provide them laser therapy or photodynamic therapy, or other therapies may be prescribed to seal the leak of these leaky blood vessels in or near the macula for wet macular degeneration. We give these Amsler grids to patients to monitor their macular degeneration at home for a sudden onset or distortion of vision. These may provide the earliest signs that macular degeneration is getting worse. And what we do is we encourage the patient to look at the grids, look at these grid one at a time, several times each week with glasses on if needed for corrected vision. And if the grid lines appear to the patient distorted or faded, the patient is educated to notify the ophthalmologist immediately and should arrange this appointment because it's telling them that their condition is getting worse. The next thing we're going to talk about is orbital and ocular trauma. Orbital and ocular trauma, the etiology is whether affecting the eye or the orbit, Trauma to the eye and surrounding structures can have devastating consequences for the patient. And the biggest thing here is prevention. Prevention is the number one way to help the patient retain their vision. So if you're educating patients or family members, we want to let them know that ocular trauma is the leading cause of blindness in children or young adults. So looking at the risk factors, we want to educate our patient that grease, frying pans, or harsh cleaning chemicals can cause ocular or orbital trauma. Workshops, if a patient works in workshops, the fragment, the dust, or the sparks can get in the eye. Around children, any sharp objects, darts or pellet guns can penetrate the eye. In the garden, lawnmowers, pesticides can, and we'll talk about chemical burns for the patient. Around the car, any jumper cables or repair shops. In sports, for children, especially contact sports such as hockey or baseball, tennis, squash, or boxing can cause devastating effects to the eye. And especially 4th of July, we love to pop our fireworks, but this can cause these types of traumas. There's different types of orbital and ocular traumas. So we have the soft tissue injury. Those are categorized as blunt or penetrating trauma. The manifestations for this is, of course, you're going to have tenderness around the area. We're going to have a swelling, hematoma or ecchymosis, a bruise. We're going to have lid swelling, ptosis or exophthalmos or hemorrhage. We can also have closed injuries that occur with contusions with subconjunctival hemorrhage. So this would cause a black eye, which in this case, we're thinking a fracture that we really can't see, but there still is trauma in that area. Orbital and ocular trauma types. In orbital trauma, which is talking about the eye socket, it's usually associated with head injuries. Hence, the patient's general medical condition must be stabilized before conducting an ocular examination. Although we are concerned for their eye, we want to visually inspect the face meticulously to assess for any underlying fracture. So that's what we're looking for here. We suspect these in cases of blunt trauma. So in the event that they were in a car accident and they might have injured themselves or they're bleeding. We want to make sure also that we examine the extent of the ocular injury, assess visual acuity as soon as possible, even if it's a rough estimate. And any soft tissue orbital injuries often result in damage to the optic nerve. So this is what we're assessing for when we assess their visual acuity. For ocular trauma involving the eye, we're going to do surgery on anything that is an injury such as a soft globe injury or prolapsed tissue, ruptured globe, or hemorrhage. So this is when the contents of the eye rupture and you can see the contents in the eye, the contents of the eye visually. And so we're going to immediately, we can't assess vision in this case. They're going to need surgery. The other types of ocular trauma that don't necessarily always require surgery are chemical or foreign object. And we'll talk a little bit more about these in depth, but for sure the first bullet there, the soft globe, prolapsed tissue, ruptured globe, or hemorrhage require surgery. Management of soft tissue hemorrhage that does not threaten vision is usually conservative in nature. So what we're going to want to do first is inspect. We're going to want to clean and repair any of the wounds. During the early phases, we're going to want to apply a cold compress followed by a warm compress. And what we're trying to do there is vasoconstrict and then help vasodilate for the healing properties to come and help start to heal. But hematomas that appear as swollen, fluctuating areas may be surgically drained. For soft tissue hemorrhage, if they cause significant orbital pressure, they can be surgically removed or evacuated. Ocular burns, this is what I was alluding to before in the ocular trauma. For ocular burns, we're talking specifically about two different types. There can be chemical or thermal. For chemical burns, we can talk about those two different types. There can be alkaline or acid, and other chemically active organic substances such as mace and tear gas also cause chemical burns. Alkaline burns such as lye and ammonia result in more severe injury actually than acids do, and we'll talk a little bit about that. Why does alkaline burns cause more severe injury? Because they penetrate the ocular tissue rapidly and continue to cause long-term damage, which in turn increases intraocular pressure, causing more damage. The acid, such as found in bleach or car batteries or refrigerants, they generally cause less damage because the precipitated necrotic tissue, it forms a protein, which is a barrier to further penetrate and damage the eye. In treating chemical burns, every minute counts. So the first thing that we want to do is we want to immediately irrigate with tap water before we send them to the ER. Once they're in the ER, we want to get a very brief history. We want to know the name of the substance that went into the eye for a chemical burn. And we look this up in the material safety data sheet to see what we can use, like in an acid, to neutralize the substance. The corneal surface and conjunctival fornices are immediately irrigated, so we irrigate as much of it with normal saline or a neutral solution. We apply a local anesthetic, and we also apply a lid speculum to overcome blepharospasm, which is spasms of the eyelid that will want to cause the eyelid to close. We want to remove any small particles, and we want to irrigate until the pH of the eye normalizes between 7.3 and 7.6. Any antibiotic ointment we instill afterwards, and then the eye is usually patched. The goal of intermittent treatment is to prevent tissue ulceration and promote re-epithelialization of the cornea. We want to lubricate the heck out of the eye using artificial tears without preservatives. We want to patch or therapeutically soft lens the eye to promote corneal reflex if indicated. We can do a grafting procedure or surgical restoration of the cornea if we need to maintain optical clarity of the eye. The second type of ocular burns is thermal, and this is caused by exposure to a hot object, such as curling iron or a tobacco or ash fall in your eye, whereas a photochemical injury caused by like an ultraviolet radiation or infrared, such as looking at snow, and the eyes reflect the snow, the sun is reflecting off the snow and it burns your eyes, or sun gazing or viewing eclipse of the sun without an adequate filter can cause a photochemical injury. Generally, these are more mild in nature, and what we do is we prescribe them an antibiotic agent, and we patch for 24 hours, and we assess the damage to the cornea. For foreign bodies or corneal abrasions, the biggest thing is after removing the foreign body from the surface, an antibiotic ointment is applied and the eye is patched. The eye is examined daily for evidence of infection until the wound is completely healed. I've had this happen where I've had a corneal abrasion and it hurt so bad. I had severe photophobia, which is ocular pain when I would look into the light. And they did prescribe me an antibiotic ointment, but what you don't want with these types of foreign body or corneal abrasion injuries is to prescribe an anesthetic eye drops or ointment, because it gives the patient the perception that nothing's wrong, and so they'll keep scratching it or they'll keep re-injuring it, and this can lead to scarring in the cornea. Now we'll talk about penetrating injuries and contusions of the eyeball. So any penetration injuries to the eyeball is when we cause injury, because something penetrates it, or there's blunt contusion force to the eyeball that it ruptures. For penetrating objects, we want to never, ever, ever remove the object because it may be holding ocular structures in place. The object must be removed by a healthcare provider. We want to cover the eye with a cup or plastic tape, and we want to allow the patient to not lay down flat. We don't want them to lay down flat because these positions may move the object. We want to not place pressure on the eye, and the client needs to immediately be seen by a healthcare provider. X-rays and CT scans are usually done to see how far the object has penetrated the eye, but an MRI is usually contraindicated because of the possibility of metal containing projectile movement during the procedure. So if we don't know what is in the object that penetrated the eye, we don't want to risk having an MRI done. Blunt traumatic injuries with an increased incidence of retinal detachment, intraocular tissue avulsion, or herniation have a worse prognosis than penetrating injuries. So while you might think it looks worse with a penetrating injury, actually a blunt trauma can have a worse prognosis than penetrating injuries, which I just want to differentiate the two. Most penetrating injuries result in marked loss of vision. They can get edema of the conjunctiva or blood within the anterior chamber. With a ruptured globe and severe injuries in the intraocular hemorrhage require surgical intervention, and we talked about this, where they have afterwards a primary enucleation, which is a complete removal of the eyeball and part of the optic nerve. And this is considered only if the globe is irreparable and has no light perception. What we know is that if the patient had a ruptured globe, a general rule is that the eyeball is removed within 2 weeks of the initial injury. And the reason we do this is to prevent the risk of sympathetic ophthalmia, which is inflammation created in the uninjured eye by the affected eye that can result in blindness in the uninjured eye. So if we don't remove the eyeball and part of the optic nerve, then the inflammation and the injury can go into the unaffected eye and affect the uninjured eye. Next, we're going to talk about retinal disorders, the etiology and risk factors. Although the retina is composed of multiple microscopic layers, the two innermost layers, the sensory retina and the RPE, which stands for retinal pigment epithelium from the sensory neural layer. I have a video of there is what is retinal detachment if you want to look at that YouTube video. But what this is that it is a condition that happens when a specific layer of the cell behind your eye come apart or get detached. The kind of detachment happens when there's been extra fluid or other material under the layer of the cells in the back of your eye, called the retinal pigment epithelium, or RPE. Risk factors are those in individuals that need glasses to see far away, or myopia, the absence of natural lenses, especially after surgery, cataract surgery, any type of trauma. If you're diabetic, you have a risk for a diabetic neovascularization, which you have formation of these new brittle blood vessels in your eye, which then can lead to bleeding and then a separation of your retina layers. Eye injury, so if you've had previous eye injury, we were talking about blunt force trauma and penetration. If you've had a previous retinal tear or detachment, or you've had a history of family members that have had this happen to them, or if you have weak areas in your retina, then you're predisposed to retinal disorders. Clinical manifestations, patients may report the sensation of a shade or a curtain coming across the vision of one eye, cobwebs, or bright flashing lights, or the sudden onset of a great number of floaters. Patients don't usually complain of pain, but retinal detachment is an ocular emergency, and it requires immediate surgical intervention for best results. Diabetic retinopathy, which is very similar to what can cause retinal detachment. The patient, if it does turn into retinal detachment, they can see an increase in floaters or blurry vision. It can go from clear to blurry. They can have dark spots or poor night vision, faded colors, or losing vision. So I mention this because these are all signs and symptoms of the retina being affected by their underlying medical condition, which then could lead to retinal detachment. The assessment and diagnostic findings, as well as the surgical management. We want to assess for visual acuity. The patient must have a dilated fundus examination using an indirect ophthalmoscope as well as a slit lamp. You also want maybe have a tomography, which is a non-invasive imaging technology that shows the cross-section of the retina. An ultrasound can be used for a complete retinal assessment, especially if the view is obscured by dense cataract, because in all of these other ones you're going through the lens, or if you suspect hemorrhage. All retinal breaks, all fibrous bands that may be causing traction on the retina, and all degenerative changes must be identified in the visual inspection. Fluorescein angiography, which lights up the blood vessels of the retina, and we want to make sure that none of those are bleeding or are brittle or blocked. Surgical management, we have a scleral buckling, and if you follow that link, it'll send you to a video on explaining what this is. But what it is the retinal surgeon compresses the sclera. You can look at figure 63-11 in your book, or a silicone band to indent the scleral wall from the outside of the eye and bring the two retinal layers in contact with each other. So it's kind of like putting a belt around the eye and keeping it intact. Vitrectomy is an intraocular procedure that allows the introduction of a light source through an incision. So what this is there's traction on the retina that can be relieved through a vitrectomy, and it can be combined with scleral buckling to repair a retinal that's been detached. What they do is they introduce gas, a gas bubble or silicone oil or some type of liquid into the vitreous cavity of the eye to help push the sensory retina up against the RPE. And then they can use laser for coagulation and to kind of help seal the two layers together to hold the retina in place. And that other one had a link to a YouTube video explaining the procedure. I'm not going to go into too much depth with the retinal vascular disorders, but they are in your book. Most of them, these that are listed, have to do with an occlusion of a vein or artery that then lead to vision loss. So loss of vision that can occur from occlusion of a retinal artery or vein. Such occlusions can result from atherosclerosis, heart disease, venous stasis, hypertension, increased blood viscosity. The risk factors for these are diabetes, glaucoma, and aging. Pathology of the external, middle, and inner ear. For the external ear, we have cerumen impaction, which is wax that usually accumulates in the external ear, and for some people it accumulates a lot and for others not so much. But they usually have this sensation of fullness or pain in the ear called otalgia. And the way that we manage this is the removal or irrigation with gentle pressure using warm water, about 50 to 70 mLs. We don't want to use high pressure because this can perforate the eardrum. Cold water can cause vomiting. We don't also want to use any matches or hairpins or any other devices because this can cause skin trauma, infection, or damage to the tympanic membrane. So we want to educate the patient on that. If we need to soften the cerumen or the wax, we can use glycerin or mineral oil before, especially at bedtime. And then hydrogen peroxide can also be prescribed to help decrease the risk for infection. Foreign body in the ear. Usually for adults, when trying to clean or remove something on their ear, this usually happens and it gets stuck in there. Children like to stick food or toys or beads, or insects can get inside the external ear canal. The standard method is irrigation, suction, and then instrumentation. So it's contraindicated for any foreign body that is vegetable or insects. We don't want to irrigate that because then they can swell and it'll be difficult for us to take it out. Mineral oil can kill some insects, so we use that first, and we want to kill them first before we remove them, or we want to coax them out by a flashlight or humming or getting them out somehow and letting them come out on their own. We want to use small ear forceps to remove objects that we can see, but we want to avoid pushing the object further into the ear canal or damaging the tympanic membrane. When we are using anything to go inside the ear, we want to be careful not to lacerate the skin or rupture the tympanic membrane. External otitis. It refers to an inflammation of the external auditory canal. The causes could be swimmer's ears, so if a patient swims a lot, the water can stay in there and cause inflammation. Any organisms such as pathogens such as Staphylococcus or Pseudomonas or fungus can cause inflammation. Systemic conditions such as vitamin deficiency and endocrine disorders, bacterial or fungal infections are most frequently encountered. External otitis is often caused by dermatosis such as psoriasis, eczema, or seborrheic dermatitis. Even allergic reactions to hairsprays or hair dyes, permanent wave lotions can cause dermatitis, which clears when the offending agent is no longer used. The clinical manifestations that we're going to see is that the patient reports pain, discharge from the ear canal. They're going to have tenderness. Occasionally they may have fever. If they have dermatitis, they're going to have cellulitis, lymphadenopathy, pruritus, or hearing loss, feeling of fullness. An otoscope examination, you're going to see that the ear canal is red and edematous, or there's yellow or green or foul smelling discharge. For fungal infections, there's going to be there could be black spores that may be visible. Medical management. The medical management is aimed at relieving the discomfort, but also eradicating the underlying cause. So we want to reduce the swelling of the ear canal, eradicate the infection like I mentioned. We want to provide the patient analgesic medications to take care of that pain. We want to prescribe them antimicrobial or antifungal medication, depending on what's causing the infection. And for us, we want to keep educating the patient to not to clean the external auditory canal with cotton-tipped applicators. Avoid events that traumatize the external canal, such as using your fingernail or any sharp object that can lead to trauma and then infection. For swimmer's ear, we want to tell them to put swimmer earplugs, and we want to check their shampoo for hair and educate them about how that could be a cause. A cotton ball or lamb's wool, when covering, can be covered in a water-insoluble gel such as petroleum jelly and placed in the ear as a barrier to the canal getting wet. Infection can be prevented using an antiseptic otic preparation after swimming. So swim ear or ear dry, unless there is a history of tympanic membrane perforation, because then this can get into the middle ear. So you can refer to chart 64-4 for more information. The middle ear, we have tympanic membrane perforation. The causes can be infection or trauma. Any trauma involving a skull fracture, explosion, or severe blow to the ear. Less frequently, perforation is caused by foreign objects like cotton-tipped applicators or hairpins that we stick in there to try to clear the external ear, like we were talking about earlier. The tympanic membrane perforation, injury to the ossicles, and even the inner ear may result from these types of trauma. Medical management. Although most tympanic membrane perforations heal spontaneously within weeks after rupture, some may take several months to heal. They can cause some scar tissue growth. In the case of a head injury or temporal brain fractures, we need to be assessing for any otorrhea or rhinorrhea that is clear, watery drainage. That can be evidence of cerebral spinal fluid instead of mucus. So we do want to be mindful of that. While healing the ear must be protected from getting wet and into the ear canal. Surgical management, the decision to perform a tympanoplasty is usually based on the need to prevent potential infection from water entering the ear or the desire to improve the patient's hearing. This surgery is usually successful in closing the perforation permanently and improving hearing. Acute otitis media. Acute otitis media is an inflammation caused by an infection in the middle ear, usually occurring as a result of blocked eustachian tubes, which prevent normal drainage. This can be acute or chronic. Otitis media is common. It's a common complication of an acute respiratory infection, such as something like viral or influenza, strep A, streptococcus, or RSV. Infants and children have eustachian tubes that are shorter, wider, and straighter, which make them more prone to otitis media. Biggest thing here is for babies, you want to feed them upright, prevent reflux, and you want to encourage breastfeeding. For your manifestations, they might have fever, ear pain, crying, irritability. For adults, they're going to have ear pain or feeling of fullness. It's going to be sometimes difficult for them to swallow. If you examine the tympanic membrane, it's going to be red. It's not going to be translucent but opaque. It might be bulging, immobile. There might be some purulent ear drainage. You might want to have the sensation of wanting to rub your ear. You want to encourage fluids, provide local heat or cold to relieve discomfort, and you want to refer to table 64-3 for the difference between external and acute otitis media. But the medical management of this is treat the underlying cause, and if it's bacterial or viral, of course, for bacteria, you want to provide early and appropriate broad spectrum antibiotic therapy. Otitis media usually resolves with no serious sequela. If drainage is needed, then we want to drain the ear, provide the patient with eustachian tubes if that's something that we see. The condition may become subacute, lasting 2 to 3 months with persistent purulent drainage from the ear. But rarely does permanent hearing loss occur, and we want to, especially with kids, we want to make sure that we're assessing their hearing loss, because sometimes they can't communicate or they're still learning how to communicate, and we want to assess their hearing. The surgical management is we might need to do a laryngotomy or a tympanotomy, which is an excision in the tympanic membrane to relieve pressure and to drain serous or purulent fluid from the middle ear. It allows drainage to be analyzed by culture and sensitivity so that the infecting organism can be identified and appropriate antibiotic therapy prescribed. Usually the incision heals within 24 to 72 hours. And then ventilating tubes, like I was talking about, also called eustachian tubes, are used to treat recurrent episodes of acute otitis media. Otosclerosis. Otosclerosis is a condition in which there's an abnormal bone growth inside the ear. It's a fairly common cause of hearing loss in young adults. If you remember back to the anatomy, there's 3 tiny bones deep inside the ear that vibrate when sound waves enter in the middle ear. You can look at that picture that I have there. These tiny little bones transmit sound waves to the cochlea in the inner ear, which convert them into signals that are sent to the brain. In otosclerosis, the stapes or the stirrup bones begin to fuse with the surrounding bones and eventually become fixed so they cannot move, which means that sound is no longer transmitted to the inner ear effectively. The signs and symptoms that we're going to see is that hearing loss can get worse over time, particularly difficulty hearing low or deep sounds and whispers. The patient's going to want to speak quietly because their own voice sounds loud to them, and they might find it easier to hear when there's background noise, unlike other types of hearing loss. Hearing sounds such as buzzing or humming that come inside your body, like tinnitus or dizziness, although this is rare. The treatment for otosclerosis is stapendectomy, which involves removing the stapes, the superstructure, and part of the foot plate, and inserting a tissue graft and suitable prosthesis. So they remove it and then they insert prosthesis. A stapedectomy is when a surgeon drills a small hole into the stapes bone, and instead of removing it, it holds a prosthesis. But in both procedures, the prosthesis bridges the gap between the incus and the inner canal, the inner ear, and it provides better sound conduction. The inner ear, some of us, I would think that most of us have had motion sickness in the past, and this is caused by a disturbance in the equilibrium caused by constant motion. What we're going to see the patient complain of and say is that they have sweating. We're going to see sweating, pallor, nausea, and they're going to complain of nausea that leads to vomiting if vestibular overstimulation occurs. And these manifestations can happen for several hours, even after the stimulation stops. Management, we can prescribe them, not prescribe them, but we can administer prescribed antihistamines like Dramamine or antivermeclizine, which may provide some relief of nausea and vomiting by blocking the conduction of the vestibular pathway in the inner ear. Anticholinergic meds like scopolamine patches can be effective because they antagonize the histamine response, which then causes like the sweating, the pallor, the nausea, and vomiting. The scopolamine patches can be applied several hours before the exposure to motion and replaced every 3 days. Side effects of these are that dry mouth and drowsiness may occur. So potentially hazardous activities such as driving or swimming, you want to try to avoid, especially with these antihistamine medications. Meniere's disease, I need you to refer to chart 64-8. What is Meniere's disease? It's an abnormality in the inner ear fluid balance. And I want to say that Meniere's disease is one of those horrific diseases that I remember having a patient, and I felt so bad for this patient, and you'll understand why, especially once we get into the signs and symptoms. But it is caused by a malabsorption in the endolymphatic sac or blockage in the endolymphatic duct. And what happens when these sacs get blocked or the fluid is malabsorbed is it causes a dilation of the endolymphatic space, which increases pressure in the system and can rupture the inner ear membrane, producing the symptoms of Meniere's disease. Meniere's disease affects about 10 to 12 of 100,000 people in the United States. So it's a pretty horrible disease, but it's most common in adults. Onset is gradually seen in adults that reach their 40s. Clinical manifestations. Clinical manifestations are, we have a triad, which is episodic vertigo. So we don't know when the vertigo is coming, when they're going to feel dizzy. Tinnitus or unwanted noise in the head or the ear. Fluctuating sensorineural hearing loss. It may include feelings of pressure or fullness, like that we've been talking in the past with some other ear disorders. It's often accompanied with, like we said, nausea and vomiting. These symptoms can range in severity from minor nuances to extreme debility. And with my patient, he had extreme debility, especially when the vertigo attacks would happen. The onset of disease usually manifests as 1 or 2, but this patient had all the signs and symptoms. He felt horrible. It was debilitating for him. He could not do anything but just stay in bed. And even when he was lying down, he would tell me that his head was spinning and he felt horrible, and there was no rest for him, and that's what made me feel so horrible for him. But assessment and diagnostic findings. So unfortunately, the physical examination findings are usually normal, which makes patients mad because they feel horrible. Sounds from a tuning fork, though, if we do a Weber test, may lateralize to the ear opposite the hearing loss, so the one affected with the Meniere's disease. An audiogram typically reveals sensorineural hearing loss in the affected ear. The medical management. Most patients with Meniere's disease can be successfully treated with diet and medication. Many patients control their symptoms by adhering to a low sodium diet, like 1,000 to 1,500 milligrams per day or less of a diet. You want to refer to chart 64-8 for that. But dietary guidelines can be useful to regulate the balance of fluid within the body. We know that sodium and fluid retention disrupts the delicate balance between the endolymph and the perilymph in the inner ear, which is where the problem is in this disease process. Furthermore, psychological evaluation and cognitive therapy may be indicated if anxious, uncertain, fearful, or depressed. And this patient was definitely anxious, definitely fearful, because he couldn't literally do anything. It's kind of like being in motion sickness all day long, and you're depressed because you can't do anything. You can't go to the bathroom, you can't drive, you can't walk, you can't go out in fresh air because you don't know when it's going to set you off. So it's a truly debilitating disease. But pharmacological therapy, we want to give them antihistamines such as meclizine, like the motion sickness, to shorten the attacks. We can give them Valium that might help control the vertigo. Antiemetics like Phenergan can help with the nausea, although you can then have drowsiness after that. So it might not improve your quality of life. Diuretic therapy such as spironolactone or hydrochlorothiazide can relieve symptoms by lowering the pressure in the endolymphatic system. The inner ear, we also have tinnitus, which is a symptom of an underlying disorder of the ear that is associated with hearing loss. Patients describe tinnitus as a roaring or buzzing or hissing sound in one or both ears. There are numerous things that can cause tinnitus, including ototoxic substances. So refer to chart 64-10. Any underlying disorders can cause tinnitus, such as cardiovascular disease, thyroid, hyperlipidemia, vitamin B12 deficiencies, psychological disorders such as depression or anxiety. So we want to see, as much as possible, try to treat the underlying cause. And we want to do a thorough physical examination to determine that cause. And we also want to do diagnostic testing. We're going to talk about audiometry in just a bit. An audiograph speech discrimination test or a tympanogram can be used to help determine the cause. Some forms of tinnitus are irreversible, though. Patients can and will need education and counseling about ways to adjust to their treatment and in dealing with tinnitus in the future. Labyrinthitis is inflammation that is rare, but it's an inflammation of the labyrinth in the inner ear. Can be caused by bacterial or viral infection. It is rare because of antibiotic therapy, but it sometimes occurs as a complication of otitis media, which is why we need to treat the infection in the first place, because it can spread to the inner ear by penetrating the membranes of the oval or round windows in the inner ear. Viral labyrinthitis is a common diagnosis, but little is known about this disorder, which affects hearing and balance. The most common viral infection that causes labyrinthitis is mumps, rubella. Viral illnesses of the upper airway can affect, if not treated, this condition, labyrinthitis. Clinical manifestations is sudden onset of incapacitating vertigo, because we're dealing with the structures that help us not have vertigo. Usually patients have nausea and vomiting, varying degrees of hearing loss and possible tinnitus. Usually the first symptom is the worst, with subsequent attacks, which usually occur over a period of several weeks to months, being less severe. Management, we want to treat bacterial infections with IV antibiotic therapy, fluid replacement, and administration of antihistamines to help with the nausea and vomiting, or antiemetic medications can also help with this. Treatment of the viral infections is based on patient's symptoms. Audiometry. It is a diagnostic procedure completed by an audiologist. It measures hearing acuity. It measures using two types of pure tone audiometry and speech audiometry. With pure tone audiometry is used to identify problems with hearing speech or music or other sounds in the environment. Speech audiometry measures the client's ability to hear the spoken word. After testing, audiographic patterns are depicted on a graph to determine the type and level of the hearing loss. There's three things that we're looking at. We're looking at frequency, which is the number of sound waves that are coming from a source, measured in hertz. Pitch, which describes frequency. For example, a tone with 100 hertz is considered low pitch, and a tone of 10,000 hertz is considered high pitch. And last, the loudness, which is the intensity of the sound, which is measured in decibels. Hearing loss is measured in decibels, and what we know is that the critical level of loudness is approximately 30 decibels or better, which is where we want to have a patient obtain when their issue is hearing loss. So just to give you an example, shuffling of papers in a quiet environment is about 15 decibels. A low conversation is about 40 decibels, and a jet plane about 100 feet away is about 150 decibels. So louder than 80 decibels is going to hurt and damage your inner ear. Table 64-2 classifies hearing loss based on decibel level. In surgical treatment of patients with hearing loss, the aim is to improve the hearing level, again, like I said, to 30 decibels or better within the speech frequencies. Middle ear endoscopy is next, and what this is examine the anatomy of the round window before transtympanic membrane, especially in the treatment of Meniere's disease. It's done in an outpatient office to evaluate suspected perilymphatic fistula and a new onset conductive hearing loss. We examine the tympanic cavity before ear surgery to treat chronic middle ear mastoid infections. In the procedure, we anesthetize topically for 10 minutes the tympanic membrane. We visually inspect the ear. We want to educate the patient about the procedure, help with the medication administration, get IV access if need be, and manage the patient's pain. And that's it, you guys. That is it for the presentation. Thank you so much for listening to the eyes, ears, and upper airway presentation.